shine, campers. It's a cold one out there. Today we're going to be talking about diabetics and their issues that are involved. And I'm going to talk about 3 reasons diabetes is sweeter than Christmas morning. Number 1, the whole bolus or half a bolus? That's the question. Number 2, HHNS, what the heck is it? And how does it deal with hyperglycemia? And number 3, glucagon, that billion-dollar drug. So stay tuned. We're going to talk about that today. So let's talk about how the body requires glucose in diabetics. So the glucose requirements for everybody's body is to just maintain the central nervous system is 2 milligrams per kilogram per minute. So let's go with the paramedic way, and that's 220 pounds. So that's 100 kilograms roughly, and that 100 kilograms times 2 milligrams is going to come out to 200 milligrams per minute. 200 milligrams per minute is what the body needs of glucose to maintain at least the central nervous system. This is just maintaining our heart, our lungs, and our brain. Now, adults typically consume 30 to 90 grams of carbs in a single meal. When they go eat that McDonald's meal, they're probably getting a little bit more, but there's just a rough estimate of 30 to 90 grams. And this contains about 15 to 20 grams of glucose. What's our dose for dextrose? 25 to 50 grams of dextrose. Okay? That's roughly twice what they're taking in a normal meal. What do we give in an oral glucose tube? 25 grams of glucose. Okay? So really, should we be giving that full tube of dextrose right off the bat when we get to these patients who are diabetics, or should we be giving them 25 grams, seeing how they're doing, maybe giving some fluids so we can get it passing through the body and getting it absorbed so that the body can start using it for sugar to turn it into energy, and the body can start waking up again out of their altered mental status. So let's be thinking about that the next time when we're about to give a whole bolus of 50 grams of dextrose. So 2 bolus or 2 half a bolus is the question. And it's up to you guys to decide that answer. So now let's talk about hyperosmolar hyperglycemic non-ketonic syndrome. So what the heck is HHNS? Well, it's hyperosmolar hyperglycemic non-ketonic syndrome. And this basically is dealing with patients who have type 2 diabetes, not type 1, and have an increased blood sugar. Their glucose, when they are in this state, is normally greater than 600 milligrams per deciliter. So what is that going to read on our point of care monitors for glucose? It's going to read high. So they're going to have profound dehydration, and they're going to have hyperviscous blood, which puts an increased risk for blood clots. This is then going to lead to pulmonary embolisms possibly. They could have delirium, which is an acute mental status change, and which is more common in HHNS than in DKA, which is diabetic ketoacidosis. This can lead to a coma, which is brought on by infection, myocardial infarction, stroke, or other acute illnesses. So to talk about it, hyperosmolar hyperketonic syndrome, those are some of the signs and symptoms there. It's similar to DKA, but they are hyperglycemic, and it causes an altered mental status, which is usually results with their drowsiness, lethargy, and possibly the delirium, as I talked about, and seizures. And that's HHNS kind of in a nutshell. So how are we going to manage that? Well, just stay tuned. Management of HHNS is going to use IV fluids because of that profound dehydration. They usually need normal saline given at a rate of 1 liter per hour for the first few hours until stabilized. Then they're probably going to need some type of electrolyte given, which is specifically potassium. And potassium is going to replace about 10 milliequivalents per hour. Once the potassium is stabilized and it's stabilizing on that plateau, they're going to start moving on towards insulin. And once they get that level and take that lab value, their insulin infusion is going to start out about 0.1 units per kilogram per hour to start out with. And that's kind of how they're going to manage hyperosmolar hyperglycemic non-ketonic syndrome. Now we're going to talk about a little bit about glucagon and why it's that million-dollar drug, and what are some uses we can use it for, and how does it work? Glucagon, that million-dollar drug we give in the back of the ambulance when we've tried giving glucose via the oral route, or we've tried getting an IV and we can't get it established and can't give dextrose. So what is our last resort? We got to go with glucagon. And we're going to give that through the intramuscular route. There's a couple different routes, and we'll talk about that you can give it, but primarily the best route is intramuscular. So glucagon acts on the liver's glycogen stores, converting it to glucose. The half-life of glucagon is between 8 to 18 minutes. So after you give it, it's going to be starting to wear off in about 10 minutes once you give it. Indication for giving glucagon is going to be severe hypoglycemia. What's the dose? 1 milligram. And we administer that via intramuscular. There is a route that you can give it IV, subcutaneous, intranasal, which is a newer one, but intramuscular is the preferred route. When we give glucagon, we need to be concerned with giving it multiple times to patients. So, for instance, if you go Sunday to a patient who is a common regular on your EMS service, and you give them glucagon and you get them awake, if you go the next day because they don't maintain their sugar on Monday and try giving glucagon again, you're not going to probably get it to work because you've already depleted those glycogen stores. So glucagon probably won't work if there are no glycogen stores. So what's another use that we can use glucagon for? And that's a beta blocker overdose. So glucagon, indications for decreased blood sugar or beta blocker calcium channel blocker overdose. So that beta blocker overdose dose is 0.1 milligrams per kilogram. So why does that work? Well, let me tell you. So both beta blockers and calcium channel blocker toxicity result in intracellular hypocalcemia. So that's low calcium levels. Therefore, the calcium salts, gluconate and chloride, are the logical first-line agents. So glucagon has become an accepted antidote to beta blocker poisoning because it stimulates c-AMP synthesis, independent of beta adrenergic receptors. Glucagon has shown positive inotropic and chronotropic. Inotropic, that's the strength of contraction, and chronotropic, that's the rate of contraction effects despite beta receptor blockade in numerous animal models and in humans. So several other studies and cases report that also demonstrated a benefit in calcium channel blocker toxicity, though many treatment failures have been noted as well. Side effects include dose-dependent nausea and vomiting, hyperglycemia, hypokalemia, and allergic reactions. So keep that in mind. It does work, and it is a accepted antidote for beta blocker overdose and calcium channel blocker overdoses because it's a great drug. So if you are going to give glucose, you're going to do the 25 grams in the oral. If you're going to give dextrose, you're going to do 25 to 50 grams, giving that IV. And if you do glucagon, you can give that IV, IN, IM, and the dose for adults is 1 milligram. The dose for pediatrics is 0.5 to 1 milligram. And the beta blocker overdose and calcium channel blocker is 0.1 milligrams per kilogram. So today I've talked about how diabetics are sweeter than Christmas morning, how we have different things that we have to be looking for when it comes to D50, and how should we be really giving the full amp of D50 or just maybe go with half the amp and then see how the patient does. How we deal with different types of conditions of hyperglycemia, specifically HHNS, which is hyperosmolar hyperglycemic non-ketonic syndrome, and also talking about glucagon and its different uses that we can use it for. So I hope this was a very helpful video for you guys. You guys have a safe and wonderful Saturday, and stay warm, because right now I'm going to finish up drinking my cup of coffee.